Hi, I'm Dr. Helena Perez. I'm the chairman of the Department of Oral and Maxillofacial Surgery here at University of Detroit Mercy Dental School. The advantage of these instruments is because using a biomechanical advantage to take the teeth out rather than just your strength, it doesn't matter how strong you are. If the instrument is used properly, you get leverage, and difficult extractions can be done very efficiently. I find that even multi-rooted teeth, for example, maxillary first molars with divergent roots, you set the beak and the bumper on the tooth and you start your rotation, and after about 30 seconds, the entire tooth will be elevated without having to section the tooth, which saves you time, and it also saves trauma to the operator as well as to the patient. Often multi-rooted teeth have to be sectioned, and that can be a little bit more stressful for patients as well as for the doctor. So I think the major advantage is to do simple extractions where they would have been surgical otherwise. Without squeezing the handles, a simple rotation towards the buccal action is used with the wrist. And as soon as you feel resistance, you hold that resistance on the tooth and allowing the periodontal ligament to break down and the bone to expand. And you hold this resistance and you continue to hold it until you feel a little pop. Sometimes this can take anywhere from a few seconds to a couple of minutes. But when you get that little pop, because of the placement of the beak and the bumper at different levels, you get an arc of rotation and the tooth actually elevates slightly up out of the socket. Once you see or feel this little lift, about a millimeter or so, you stop with a PHYSICS forceps, you put this instrument down, and you can use any type of pincer device such as a rongeur or a universal forceps to remove the tooth occlusally. If this is done properly, it prevents any damage to the buccal plate, and the teeth can be removed quickly and efficiently and atraumatically. I would say some good tips would be to go slow, not to try to rush the procedure. It feels like it takes a long time because you're not doing some of the multiple movements that we use with conventional forceps. You're simply holding a resistance on the tooth, so even a few seconds may seem like a long time, but if you count to yourself, it rarely takes more than a minute to get movement of the tooth out of the socket. So just be patient, hold the pressure on there, and remember not to squeeze. I find that being very far back on the handles helps a lot because it increases your leverage, and it makes the forceps work more efficiently that way. You don't want to choke up on the handles like you do with some other forceps. You want to be very far back.
Hello, I'm Mark Setter, and I'm a periodontist from Port Huron, Michigan, and I'm here on behalf of Golden Mish Forceps to explain my experience having used these instruments for the past 2.5 years. In an effort to explain hand position in each quadrant, I'd just like to show you how I use the hand position in the forceps in the various quadrants. In the upper right posterior, I like to have a finger between the handles that acts as a spring that allows me to vary the hand distance. And so in the upper right, I can place the bumper, position the beak. You can notice the hand position I'm using allows me to vary that distance, whatever I need that the anatomy determines. Then I can provide the rotation pivot point. So that would be an upper right hand position. An upper left hand position is going to be somewhat similar, but again, I've got a finger in between the handles to allow for some variability of beak position, but then positioning the beak, again, delivering at least initial luxation with a pivot point. Again, it's not squeezing. You got to get past that. That's very difficult given our dental history. But you can vary the pivot point here just by moving your hand. Once it's set, this hand position is fixed. At that point then, you can provide delivery. For the lower arch, lower left posterior, again, I've got a finger positioned between the beaks. I'll lock one handle in between my thumb, the other off to the side, then can position accordingly. For the lower right, that's when I put 3 fingers between, hold it between my thumb and my baby finger, and deliver this way. So that's a lower right hand position. Where you're doing the extraction in the mouth determines how much buccal shelf or buccal tooth bone position you have. And if you're familiar with the golden Mish forceps at all, the bumper needs to rest on buccal bone. When you're in the posterior, that buccal position brings the bumper quite a bit towards the occlusal table and out towards the buccal. And if I could demonstrate that here with a second, third molar forcep, you can see that the bumper is quite a bit towards the occlusal table. So when you rotate, there's a vector of lift greater than there's a vector of buccal tooth movement. But when you get in the anterior, there's quite a bit of undercut involved with the buccal bone. And so if you position the bumper in the anterior area, that undercut causes there to be quite a bit of buccal vector, buccal torque, if you will. There's lift, which is the point of the forcep, but there's also a buccal vector of force. So what I've done in my technique is I will take gauze and fold it, maybe take a couple of pieces of gauze, and fold it and rest that in the vestibule to eliminate the undercut. And in eliminating the undercut, I get more occlusal or lift force and less buccal vector. And I'll see if I can't demonstrate that for you. The gauze is sitting in the vestibule, and then the forcep bumper is put in position, but with the wad of gauze there, we eliminate the undercut basically, so that now when you're using the instrument, you get a higher amount of lift and less buccal force direction. So I find I use that more and more. Now, again, the point of the forcep is not to deliver the tooth, but rather to provide initial movement. Once you get the tooth to move a millimeter or two, I deliver it with a rongeur or a conventional forceps.
Hi, I'm Dr. Jim McHenry, and I've been practicing dentistry for about 28 years now, and I've been using the PHYSICS forceps for over a year. If I could just demonstrate basically how this works. It is all physics, as is in the name. The bumper is first put on the buccal plate. If you're extracting this tooth, you're going to come up in front of it, say, for example, number 25, and then I'm going to place the beak below the enamel cap, down by the CEJ, and I'm just going to apply light pressure with a slight turning of my wrist. Now I'm just going to hold that pressure, possibly for a full minute. And what happens is those fibers that make up the PDL gradually begin to separate. And as soon as I feel even just 1 to 2 millimeters of movement, I know that that tooth is ready to come out. So I'm done with this instrument. And I pick up my ash forceps or whatever other forceps, rongeurs, and to just take it and remove it at that point, because it's easy, it'll just pull right out at that point. One of the other things that after using these for a while, you pick up some of your own tricks too. For example, just to change a little bit the vector of the force in the lift, the angle of the lift. You have some pretty delicate bone in the front of these lower anteriors, so rather than applying the bumper directly to the bone and the vector of force being a little too buccal, I might sometimes put a cotton roll on that bone that changes my angle from here to here, and now I'm getting a more direct vertical lift as I rock my wrist and hold. Now those fibers are being stretched more vertically than buccally, and that's going to preserve my bone a lot better in the long run. Make it easier for me to preserve that for an implant or simply for a nice ridge under a bridge.